Hi guys, good evening, good evening. Can you all see me? Can you all hear me? Can you all see me? Can you all hear me? Great to see you guys back. Hello, hello everyone. Good evening guys. बेटा चाहे कितना भी टाइम हो गया हो, I know it's been a little longer break, but the break was because of our NEET PG INICET and FMGE exam. तो एग्जाम सीजन के टाइम पे थोड़ा बहुत ब्रेक लेना पड़ता है, ठीक है. But anyhow, I'm great. Thank you so much. I mean, my inbox has been buzzing since the day we had put the BLS on hold. We are kicking back again. So, as most of you are aware, I'll just quickly brief it again. Now the BLS is going to be 3 days only, but now we call it as BLS Pro. Reason: first 2 days we'll do pure video. I mean your Bailey lectures, which are going to be theory topic based, and then the last day, that is the third day, that is the Wednesday, we'll be doing MCQs also, so that you get oriented to the competitive exams as well. Now, without wasting any further time, I hope everybody knows today's topic for discussion is going to be our small intestine. Right. So I'll try to take you through the entire components of the small intestine, their disorders, and how things are going to change. What is the basic objective? Now, as we've been doing in every BLS class, we'll do the same thing. We'll start with the basic anatomy. We'll try to understand the core concepts of anatomy and its physiological component, and then try to add slowly disorders so that we'll be able to understand better. Right. Amazing to see you guys, all of you back here. I missed this interaction, right? Right. So what we'll do is, let's do the lecture first, and then we'll have a time to chit chat, and then we'll see, what are the other concerns that we can address. ठीक है. तो without wasting any further time, पहले पढ़ लेते हैं थोड़ा सा. बहुत दिन हो गया, मैंने भी नहीं पढ़ा है, आपने भी नहीं पढ़ा. तो let's have that little bit of the energy burst, and then we'll kick it from there. ठीक है. तो when we talk about small intestine, the small intestine predominantly consists of your duodenum. It consists of your duodenum, your jejunum, and your ileum. Duodenum is fairly considered to be a part of proximal intestine, so we're going to leave it behind. We will be considering our core small intestine as your jejunum and ileum, and this is what is going to be our major part for discussion as well. ठीक है. Okay. I missed. Okay, thank you. Next will be BLS Pro Max. नहीं बेटा, will be Pro 1, Pro 2, Pro 3. ठीक है, till we go Pro 10. Don't worry. Right? चलो. Every Wednesday will be our MCQ day. ठीक है, every Wednesday will be our MCQ day. ठीक है. चलो. So when we talk about small intestine, let's take you through the embryonic journey of it and how it is going to shape you in that context. तो the small intestine the development जो है ना, the whole concept of the development actually takes shape during the 4th week of the embryo. So the 4th week of the embryonic development is the point where the small intestine will start to develop. So this is basically your start point. Okay. Now what is going to happen is, this is basically when you talk about the guts in general, we say the foregut is there, then we have the midgut, and then we have the hindgut. All that differentiation and the development will actually start taking place from the 4th week itself. Now, what we observe is, during the 5th week of the embryonic development, this is a very important week, because this is where the bowel will start to grow very rapidly, and this is what we call it as the rapid increase phase. So this is where there will be your rapid increase phase. Will be rapid increase phase of the bowel development, right? Now, what this is rapid increase phase basically keeps you in the context. Now, if you take this as a representation of the embryonic component, and let's say this is where the umbilical opening is present, right? Now, just for the sake of understanding, I'll say this is going to be the yolk sac, right? Then you have the foregut, everything is there. So we'll just put it across here. This is the foregut. This is the hindgut that is present, just for the sake of understanding. Putting across here. Then you have the midgut. Now we know that there is no enough space inside the coelomic cavity for the midgut to develop, and it is going to span across a lot of space. So what body does is it says एक काम कर भाई midgut मेरे पास अंदर जगह नहीं है डेवलप होने के लिए, तू थोड़ा बाहर चला जा, ठीक है. So what it does is it pushes the midgut from the umbilical opening. It pushes the midgut from the umbilical opening into the external space. So it is now going into extracoelomic space, right? So you can see the midgut is now being pushed outwards. Midgut को ना बाहर पहुंचा दिया. So for the sake of understanding, this is going to be your foregut, this is your midgut, and this happens to be your hindgut, right? Now the midgut is forced to go out of the embryonic cavity, and we have asked the midgut to develop. Now what is interesting here is if you look at the midgut, I can divide the midgut into two parts. This is the proximal part of the midgut, or also called as the cranial end of the midgut. This will be called as the cranial end of the midgut. This would be called as the cranial end of the midgut. This happens to be the cranial end of the midgut. Then you see the lower part which has been left around. This, if I just add another color to it, okay, so this is what we call it as the caudal end of the midgut. So there are two parts of the midgut because midgut is quite extensive and quite big. So we have divided them into two distinctive parts, the cranial and the caudal end. The caudal end of the midgut. ठीक है. So दो पार्ट हो गए midgut के, ठीक है. एक तो आपका cranial end हो गया, दूसरा आपका caudal end हो गया, right? Now what happens is this continues to develop. ये जो आपका cranial end है, the cranial end, it is going to develop. क्या क्या बनाता है? ये आपका distal part of the duodenum बनाता है. It forms the distal duodenum. That is the third part of the duodenum and the fourth part of the duodenum. This is also going to create duodenum हो गया, ठीक है. Then it is going to form the proximal ileum. The proximal ileum. The caudal end, on the other hand, is going to develop into the rest of the distal ileum will be formed. Along with that, it is going to form the cecum, the ascending colon, and the proximal two-third of the transverse colon. So I'm going to write that it is going to form till the proximal two-third of the transverse colon. ठीक है. तो midgut, मुझे देखो midgut मोटा मोटा मुझे पता है that it is going to form from the distal part of the duodenum to the transverse two-third of the transverse colon. लेकिन मुझे ये नहीं पता था कि कौन सा पार्ट बनाता है. तो cranial end क्या बनाता है? The cranial end actually forms the distal part of the duodenum, that is the D3, D4, and the proximal ileum, and the caudal end forms the rest of it, that is the distal ileum. The ileum का बचा हुआ part, and then till the proximal two-third of the transverse colon. Now you see this is the junction. This happens to be the junction between the cranial and the caudal end. Between the cranial and the caudal end of midgut. Embryonically, इसका क्या relevance है? The relevance is there is a duct that is going to arise from the yolk sac, and this duct is going to go and attach at this junction. ठीक है. ये जो duct है ना, जो yolk sac से निकल के आ रही है, this is your yolk sac. This happens to be your yolk sac. अब ये yolk sac से जो duct बन के निकल के आ रही है, and that duct is going to precisely go and hit, or it is going to attach to the junction between the cranial and the caudal end of the midgut, or this duct is your famous what? It is your vitalointestinal duct. This is your famous vitalo-intestinal duct. Many a times we don't even understand कि भाई ये vitalo-intestinal duct बना कहाँ से, आता कहाँ से, कौन लेके आ रहा है, कहाँ अटैच करता है. Now we have a sound understanding कि ये vitalo-intestinal duct क्या बला है. ठीक है. Now we understood. Now इतना होते you think the component is done? No. Now this is on the 5th week. अब होता ये है कि जितना काम हो चुका है, then it goes to the बाकी जितना whatever I've told you, the development continues all the way until the 10th week of gestation. फिर आपको वेट करना है 10th week of gestation पे. The 10th week of gestation is the re-entry. This is now celebrated. जैसे भगवान राम वापस आए थे वनवास से, ऐसे ही आपका मिडगट वापस आएगा. ठीक है. सो दैट्स द री-एंट्री that is going to take care. ठीक है. Now what is this re-entry? The re-entry is of the midgut. Now this happens to be the embryonic cavity that you have. This was where the umbilicus was present. We're not worried about it. This is the yolk sac. बाकी जो foregut जो बनाना था बनाता रहा. It is formed, just for the sake of understanding, this is formed until the duodenum here. The hindgut was forming whatever the rest of the transverse 2/3 of the colon was there. So just for the sake of understanding, I am highlighting the hindgut here. So hindgut, rest of the transverse 2/3 of the colon, sigmoid, the rectum was formed. बाकी तो cloaca बनाएगा. तो यहाँ तक ये आपका hindgut हो गया. अब ये जो midgut था ना, which was outside. Now you remember the midgut which was outside this had to take a re-entry because the midgut was the one which was forming the rest of the duodenum. जो बचा हुआ डिओडिनम था वो बना रहा था और until the transverse 2/3 of the colon. So this entire bridge was actually your midgut, and this is actually attached by this small duct which is present, and this is what we call it as the vitalo-intestinal duct. By the time of the birth, the vitalo-intestinal duct basically disappears. Okay, no need to worry about it. Now the interesting part is when it has to enter. Now it's a common sense na कि इतना बड़ा component है and you're trying to pull it in, it is becoming very difficult. So if a small opening and you have to push it in, what will do? You try to squeeze it and then push it, try to squeeze it, then just push it. If you have this common sense, your body is much more intelligent than you are. So obviously body बोलती है कि I cannot genuinely pull it because there is a small opening, there's a big component coming out. I have to pull it back in. So what I'll do, I'll rotate a bit, then pull it, rotate, and then rotate, pull. So there has to be two things. There has to be rotation and there has to be pull. So basically, there has to be 390 degrees, 3 right angle turns before it enters. Okay? So what happens is it turns one right angle once. Okay? So it is like 1, 2, and 3. So 3 right angle turns it is going to take. So total rotation is going to be of 270 degrees. In which direction? It is going to be in the anti-clockwise direction. It is going to be 3 times right angle turns that are 90-degree turns. So a total of 270 degrees rotation is going to happen in an anti-clockwise manner, and then the re-entry is going to be facilitated. So ultimately the re-entry is going to be at this particular point. Okay? Did you all understand this? Now, by the time the re-entry is completed, what is the abdominal status? That is also very interesting. So initially, I'm not saying eventually, we all know what are the organs and where they're going to present. This is what I want you to remember, because when we talk about malrotations, we talk about all the congenital deformities, this is going to play a very important role. ठीक है. ये जो midgut है ना, before it goes in, the midgut has to come back into the abdominal cavity. Now when it comes back, it will rotate. It is going to rotate in a anti-clockwise manner, and that rotation is going to be around the axis which is going to be governed by mesentery itself, and that is going to be at 3 right angle turns. That is going to be 3 right angle in an anti-clockwise manner, which is called as 270-degree turn. So eventually what is going to happen? You will notice the proximal jejunum is the first one to enter. So this is going to be the right side of the abdomen. This is going to be at the left side of the abdomen. Just for the sake of understanding, I'm just going to draw a midline. So right and left ka differentiation is there. The proximal jejunum is going to occupy. This is going to be the proximal jejunum that is going to occupy the left side of the bowel. ठीक है. The rest of the bowel is going to occupy the right side, right? The rest of the bowel. When I say rest of the bowel, that is going to be your distal jejunum, your entire ileum, your entire colon. Everything is going to be right side. And what is the carry home message? Remember, the cecum's initial position is here. That is right upper abdomen. सीकम जो होगा वो इनिशियली आपके राइट अपर एब्डोमेन पे होगा. धीरे 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 वो अपने आप एडजस्ट होके दे विल कम बैक टू देयर ओरिजिनल पोजीशन. सीकम इज गोइंग टू डिसेंड डाउनवर्ड्स and you will see the colon is going to stand tall. That is going to be ascending colon, then you have transverse colon, then you have descending colon, and all that is going to happen. This is the most important orientation that you need to keep in the development of the bowel. During the initial form, when the re-entry occurs, proximal jejunum will be present on the left side of the abdomen, rest of the bowel will be on the right side, the cecum is present on the right upper abdomen. ठीक है, this is the presenting component. Is everybody clear with this? ठीक है. Did I overburden you with information? Quick feedback. I hope so. No. Okay. Let's take a quick recap. What did we learn about it? We said we're talking about the small bowel's development. It starts from the 4th week. 5th week is the rapid increase phase. During the 5th week, you will see the midgut is going to expand very fast because the body does not have enough space. It pushes the midgut from the umbilical opening into the extracoelomic space and it tells the midgut, ja, जी ले अपनी जिंदगी और जब बन जाएगा तो वापस आ जाना. ठीक है, तो मिडगट जाता है बाहर, अपने आप धीरे 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 करके ग्रो करता है, ग्रो करता है, ग्रो करता है. बाय द एंड ऑफ द 10th वीक जब डेवलपमेंट कंप्लीट हो जाती है, बोलते हैं कि घर वापस आने का टाइम हो गया. अब वापसी जो होगी वो मिडगट बिफोर इट एंटर्स इट इज गोइंग टू रोटेट एंड देन गो इनसाइड. तो घूमते घूमते अंदर जाता है. ये जो रोटेशन है दैट इज गोइंग टू बी 3 राइट एंगुलर टर्न्स, दैट इज 90 degrees each to a 270 degrees in an anti-clockwise manner, and then it regresses back. Okay, so this is the basic entry component that you need to know. Another very interesting thing is, where is this vital intestinal duct attached? Where does it arise from? It arises from the yolk sac. It attaches at the junction between the cranial and the caudal end of the midgut, right? That is what you're supposed to keep in your mind. Sorted? Okay. Now, once the development is complete, we'll talk about few factual components about the small intestine. I'll take a quick component here. So when I talk about the small intestine, when I talk about the small intestine, you will see the total length. Now it varies from specimen to specimen, human to human, every other component. But the total length that is being reported is around 300 to 850 centimeters. It is longer in males when compared to females. Okay, so length of the small bowel is longer in males when compared to females, right? Now in this length, if I have to differentiate between the jejunum and ileum, I hope everybody knows that ileum is longer than jejunum. So if I take in the percentage manner, 40% of this entire length is going to be jejunum, and 60% of this entire length, it is going to be ileum. Okay, so 40% comprises of jejunum and 60% comprises of ileum. Now, very important thing is, clinically, if I say intraoperatively, I give you the bowel in your hand and I ask you to identify, to differentiate between the jejunum and ileum. Will you be able to do that? Now, a $1 million question. A good surgeon would actually, obviously, without any hesitation, he will be able to differentiate. But a jejunum is also from the midgut only, no? Okay? Now, let's try to understand how do you differentiate. So what I'll do is, I will give you two components of the bowel. This is one segment of the bowel, and this is another segment of the bowel. By looking at it, can you tell me which is jejunum, which is ileum? Just here. You can see right across here. ठीक है, इन दोनों को देख के क्या आप डिफरेंशिएट कर सकते हो कि कौन सा जेजुनम है कि कौन सा आइलियम है? आप नहीं कर पाओगे. तो मैं क्या करूंगा, आई विल से एक काम करते हैं, यहां पे आपको एक बॉर्डर दिखाते हैं. दिस इज योर मेसेंटेरिक बॉर्डर. ठीक है. नाउ द बाउल हैज टू सर्फेसेस. One is a mesenteric border, another one is your anti-mesenteric border. Just for the sake of understanding, I'm going to put it here. This is what we call it as the mesenteric border, which is here. And this is what we call it as the anti-mesenteric border. This is what we call it as the anti-mesenteric border. Okay. So there are two borders. One is a mesenteric border, another one is an anti-mesenteric border. Now, what is the fun in knowing this? The fun in knowing this is the blood supply predominantly for the bowel comes from the mesenteric border. Okay. Anti-mesenteric border ऐसे है. It is there, it means there. Now, I'm going to show you a small differential component of the blood supply so that you will be able to identify better. Now, this is the blood supply to the small bowel. It is predominantly supplied by superior mesenteric artery. There is no if and but in that. We'll talk about it when we talk about colon. This is a beautiful architecture that we have to discuss there. Okay. So here you see in this part of the bowel, you see the blood supply and its blood vessels are going to be in this particular fashion, right? So see, there are very minimal branching and you see there are longer branches which are going to come. So this is how the blood supply to the bowel is going to present here. Okay. When you look at on the other side, this end of the bowel will also have a similar vascular supply, but you will see a marked difference in its arrangement. You will see there is a marked difference. You see the multiple branchings. These are called as arcades, right? The multiple arcades are present. And among these arcades, you see extensive blood markings are there. And along with that, you will see the terminal supply is going to be very short vessels. Unlike, I would say that this is our specimen number 1 and this is specimen number 2. You see in specimen number 2, there are smaller branches, smaller vessels which are supplying to the bowel wall, and there are multiple branching which are occurring. These are what we call it as the arcades. Now, by looking at these specimens, can you tell me which is jejunum and which is ileum? So just for the sake of understanding, if I have to mark it down, these are what we call it as the vascular recta, the principal supply. This is what we call it as the vascular recta. And this is what we call it as the arcade. This is what we call it as the arcade, right? Now, when you look at this on the either component, in the specimen number 1, you have, when you talk about the vascular recta, they're longer vascular rectus. These are long vascular rectas and they are minimal arcades. They are minimal arcades. Whereas here you can see there is a short vascular recta and there are multiple arcades. And this is how you can differentiate between jejunum and ileum. Which is jejunum, which is ileum? Somebody has given me a right answer. Absolutely correct, Abhishek. The answer is going to be specimen number 1 is going to be your jejunum, and the specimen number 2, it is going to be ileum, right? So clinically, or when you look at in your intraoperative component, this is how you differentiate between jejunum and ileum. A jejunum is going to have a longer vascular recta with minimal arcades. Ileum, on the other hand, will have a shorter vascular recta, but it will have multiple arcades. That's how you differentiate between jejunum and ileum. Another beauty, forget about jejunum, ileum, whatever it is. Now, as I told you, the bowel has two components. One, it is going to be your mesenteric border, another is anti-mesenteric border. I'll just take it here. Now, let's say this is how the bowel wall is going to look like to us, right? This is the entire component. Now, the interesting thing is, as you can see, this is the mesenteric border. The mesenteric border is going to be on this particular front. Okay? So, this is the entire mesenteric border that you have. Now, what is interesting for us to know is whenever the vascular supply is going to come, let's say it is coming from the mesenteric border, this is how the vascular component is going to come across it, right? The interesting thing is the blood supply will come from the mesenteric border. It is going to pierce the mesenteric border. So you will now notice that there will be a small rent on the bowel wall on the mesenteric border. So blood vessel pierces the mesenteric border. After it pierces the mesenteric border, it will now go into the wall and supply the blood to the anti-mesenteric border. So there is no specific blood supply to the anti-mesenteric border. The blood supply to the anti-mesenteric border also comes from the mesenteric border after piercing the mesenteric wall, and then the blood goes to the anti-mesenteric wall, right? Guys, I will respond to the chats. I will respond to the chats only when it is valid for my subject concern. Okay? I don't entertain if it is non-subjectual. I don't entertain when it is not relevant to the current discussion and if the question is not valid. If you have any personal questions, you have my group, you have my Telegram and the Instagram ID. You can definitely send your questions down there. I would be more than happy to answer, but I would not entertain any sort of disturbance during the lecture. Okay? Right. So now here is the component, right? So as I told you, the most important fact is the blood supply. The blood supply comes from the mesenteric border. It comes from the mesenteric border. Then it pierces the bowel wall. The blood vessel, it is going to pierce the bowel wall. It is going to pierce the bowel wall. And then it supplies to anti-mesenteric border. Then it supplies to anti-mesenteric border. Now, why do you want to know so much in detail? Okay. Why do you want to know so much in detail? The concept is very simple, right? What is it? When a bowel is being pierced, right, by a blood vessel, that piercing is going to create the weakness in the bowel wall. So where is the anatomical weakness? The anatomical weakness in the bowel wall. The anatomical weakness in the bowel wall will exist where the blood vessel is piercing the bowel wall, and that is going to be your mesenteric border, right? And that is why when we talk about the disorders like diverticulosis, that will usually, predominantly, always will be on the mesenteric border because there is the anatomical weakness. We have already discussed in our esophageal lecture that the prerequisite of development of a diverticulum, it is going to be increased age, it has to have an anatomical weakness and a trigger factor. Now in the bowel, I know the anatomical weakness is on the mesenteric border. So it is the mesenteric border. It is the mesenteric border that has the anatomical weakness. Now, if I ask you a very logical question, just look at the diagram and just let me know which part of the bowel will receive less amount of blood compared to the component. Okay? Right? Now you have two components. You have the mesenteric and the anti-mesenteric borders of the bowel wall. Which part of the bowel wall will receive less amount of blood? Mesenteric or anti-mesenteric? Quick feedback. Which part of the bowel will receive less amount of blood? Mesenteric or anti-mesenteric? As you can see, usually the blood is going to flow in abundance to the mesenteric border once the mesenteric wall is taken. Now it is the same thing, no? कि आपके घर पे खाना आएगा, उसके बाद आप पड़ोसी को दोगे, ठीक है? तो ज्यादा खाना किसको मिलेगा? आपको मिलेगा कि पड़ोसी को मिलेगा? ऑब्वियसली जब आप खा लोगे, आपका पेट भर जाएगा, बचा हुआ खाना आप पड़ोसी को दोगे, तो ऑब्वियसली दैट विल बी लेसर. In a simple context, if the food available to you is there and then you have to give it to your neighbor, obviously you'll consume first and then leftover will be given to neighbors, and the leftover food will always be less than the original one. So obviously the blood supply to the anti-mesenteric border is lesser when compared to mesenteric border. So the question is, which part of the bowel side is more prone for ischemic bowel injuries? Remember, more common site for ischemic bowel injury it is going to be your anti-mesenteric border. This is going to be your anti-mesenteric border. This is going to be your anti-mesenteric border. क्लियर? ठीक है, ठीक है, राइट गाइस. करेंटली वी आर डूइंग जीआईटी, तो थोरैक्स आने के लिए टाइम लगेगा. प्रॉबेबली इट विल टेक अनदर 3 months एटलीस्ट. ठीक है, तो डोंट आस्क मी दी थोरैक्स अंटिल नेक्स्ट 3 months. अभी जीआईटी चल रहा है. ठीक है, so obviously the anti-mesenteric border is more prone for ischemic bowel injuries. Tumors on the other hand, they grow towards their blood supply which is on the mesenteric side. So tumor induced bowel perforation are usually on the mesenteric side. That we'll discuss as we go forward. ठीक है, इधर तक everybody is clear with this, right? Now the other important differences between the jejunum and ileum. तो jejunum और ileum में क्या basic फर्क है? When you compare to the ileum, jejunum is wider in diameter. It is going to be wider in diameter. This is going to be thick walled when compared to ileum. There will be presence of prominent mucosal folds. This can be seen radiologically also when you do a contrast imaging, and this is what we call it as the valvulae inconventi. This is what we call it as the valvulae conventus. This is what we call as the valvulae conventus. Okay? Now, ileum on the other hand, when you look at it, this is going to have thick and fatty mesentery, not the wall. It is thin walled when compared to the jejunum. It has got hypertrophied mucosal folds. It is called as hypertrophied lymphoid, or the lymph nodes are called as the lymphoid aggregates. And these are what we call it as the Pear's patches. These are what we call it as the Pear's patches. Okay. In fact, Pear's patches has another clinical significance that we'll talk about in the bowel obstruction. When we talk about intestinal obstruction, interception के लिए one of the most common lead point in an age group between 6 to 10 months is a hypertrophied Pear's patches or the mucosal folds. Post rotavirus infection where the baby is going to have diarrhea. Post diarrhea, if there's interception, it is going to be because of this particular component. ठीक है. Jejunum from the cranial end, beta. Jejunum is from the cranial end. ठीक है. So this is the basic component that you need to know with respect to jejunum and ileum on the anatomical front. ठीक है. तो अगर इसको थोड़ा you go into the bowel wall, slightly, I mean we have already discussed the entire GI wall, but थोड़ा सा इसको अगर आप और थोड़ा डिटेल में देखोगे, so what does the bowel wall have in for us? So when you look at the entire component, it all starts with the mucosal layer. So I'm not going to take away from it. This is going to be mucosa. Next to the mucosa, you have the submucosa. So we are keeping this as the submucosa. Next to the submucosa, you have the inner circular muscles. So we still have the inner circular muscles. And after that, you have the outer longitudinal muscles. And because it is covered by the visceral peritoneum, and the visceral peritoneum is what we call the serosa. Okay? Now, this is nothing short of what we have already learned. So there's no hype around this, but I'll just simply write it. This is going to be mucosa. I will tell you what is more important here. Next to the mucosa, this is what we have is your submucosa. Then you have your inner circular muscles. So you have the inner circular muscle and the outer longitudinal muscles. and the outer longitudinal muscle. Outer longitudinal muscle. And the last one that you have, this is our serosa. This is your serosa. This serosa is also called as your visceral peritoneum. It's a fancy word to tell you that there's presence of visceral peritoneum. It's a fancy word to tell you that it is visceral peritoneum. See? Okay. Thank you guys. Please do not spam it also. I do understand the enthusiasm, but let's keep it absolutely professional. Okay. So this is what you have in general as a bowel wall. Now, when I take the mucosa, just take the mucosa and try to understand mucosa, right? Especially in the small intestine. When you look at the mucosa predominantly has three basic layers. Okay? What are the three layers of the mucosa that you have? The first one is going to be the epithelium. The second one is going to be your lamina propria. And the third one is going to be the muscularis mucosa. Your muscularis mucosa. It is your muscularis mucosa, right? Now, it is very interesting for you to understand that in the small intestine, this epithelial folds are well developed. Okay? So what is going to happen is this mucosa which is present, no, I'm just going to tell you the mucosa. This whole component of mucosa, they are going to be arranged in a wavy pattern. So this is how the mucosa is going to be arranged. So this is the arrangement of the mucosa that you see. Now, as I told you, there are three layers of the mucosa. The outermost layer that you will see is going to be the epithelium. So this is the epithelium. Now, because as you can see, the mucosa itself is becoming wavy. This dip in the mucosa is creating a basically like a crypt, and hence these are also called as the crypt components. Okay? This is also called the crypt lumen or the crypt component. I'll explain you in a bit, so don't worry about it. So this is how it basically looks like. Okay? So this is the epithelium that you have. So the outermost layer in the mucosal component is going to be your epithelium, right? So this is how the epithelium is going to be present, right? So this is the epithelial surface, which is the outermost layer. Now they vary according to different cells. There are predominantly 4 different varieties of cells which are present in the small bowel. Each one of them have their own important roles. We'll talk about it, but for now you should know that the outermost layer of the intestine is going to be your epithelium. I'm just trying to make it more precise so that you understand it without failing or without even considering. Okay, so the outermost layer that is formed, this is your epithelial component, right? Now, under the epithelium, you have the lamina propria. So this layer which is going to be present, this is going to be your lamina propria. This layer that we're trying to indicate is going to be your lamina propria. Now, within this layer, you have the vascular supply and your venous drainage. Along with that, you have your lymphatic components also, right? So I'll use orange as your lymphatic component. This is your lymphatic drainage as well. This is going to be through the scripts, right? And at the base of this, you have the muscular layer, and this muscular layer that is present, this is what we call it as the muscularis mucosae. This is what we call it as the muscularis mucosae. We've already discussed it. The blood supply to the entire gut wall is going to come from the submucosa, and then it is going to supply to the rest of the components, right? Now, what are the various components that you have? When you look at these cells on the small bowel has something very interesting. They have these small brushes. Now see, these hair-like structures is what we call it as villi, and that basically increases the surface area of absorption, and that is their basic game that is important. So I'm not going to put it across here, but you need to understand that this is going to be present all across here. Now these brush borders which are present is what we call it as villi. So villi are basically here to increase the surface area of the absorption, and hence the villi becomes a very important integral component of your small intestines anatomy. Okay, so this is the basic villi which are present on the cell surface, right? So these are the villi which are present, right? Now, no, I'm not in the head office beta, so please stop bothering me about it. Okay, now, so what you have, these are what we call it as the villus epithelium. This is what we call it as the villus epithelium. This is what we call it as the villus epithelium. Now you see this dip that you see here, this fold that is created by the mucosa, this is what we call it as crypt. This is what we call it as the crypt lumen. This is what we call it as the crypt lumen, right? So the villus epithelium is there. The lumen that is created is what we call it as the crypt lumen. And the topmost layer, which is the highest, which is present here. When you look at this area which is on top, तो एक तो सबसे ऊपर वाला एंड हो गया एक डिप्रेशन का. डिप्रेशन को तो आप क्रिप्ट लूमेन बोल रहे हो. ऊपर वाले एंड को क्या बोलोगे? दिस इज कॉल्ड एज द सेल एक्सक्रूशन जोन. This is what we call it as the cell extrusion zone. So यहाँ पे cells are dislodged. ठीक है. These are your cell extrusion zone. From here the cells are going to be let off. Clear? ठीक है. So this is the basic objective. Rest everything remains the same, right? So crypts are formed from these mucosal fold components. Everybody is clear with this? Great. ठीक है. Now, mota, if you talk about it, what are the various important components and what do they do? What is their functional status? Let's say this is the esophagus, this happens to be stomach, this happens to be the duodenum. I'll use a different color. Let's say this happens to be the jejunum that you're keeping across here. Following jejunum, let's say this happens to be the ileum. This is going to be ileum. So let's talk about it, their individual importance, right? So when it comes down to duodenum, what does duodenum basically absorb? Okay, so when it comes down to the duodenum, see duodenum से क्या क्या absorb होता है? Number one, amino acids are going to be absorbed. Number two, iron is going to be absorbed. Water is going to be absorbed and basic electrolytes. Somebody will tell you that disaccharides are also, but not important from our current point of discussion. Next, when you look at the jejunum, so what gets absorbed from the jejunum? Jejunum से क्या absorb होता है, right? So in jejunum, when you look at it, you have the monosaccharides and the disaccharides. Mono as well as disaccharides. Mono as well as disaccharides. Folate. Then you have vitamin, that is your fat. I mean, we can say vitamin A, D, E, and K, right? Then you have calcium, it is going to get absorbed. Your magnesium gets absorbed. Your zinc gets absorbed. And your copper gets absorbed, right? All these are going to be absorbed from the jejunum. What does ileum take away? So when you talk about the ileum's absorption, ileum predominantly takes vitamin B12, Castle intrinsic factor, which is produced by the parietal cells inside the stomach, and enterohepatic circulation, that is going to be bile acid. Remember, 95% of the bile is going to be absorbed, only 5% is excreted, and that is going to be via this. So ileum is going to be B12, Castle intrinsic factor, and the bile acids, right? Now, when we talk about the electrolyte imbalance, usually the question is asked, if you remove jejunum, what is the electrolyte imbalance that you can see, or which vitamin deficiency can you see? You have the answer right in front of you, right? On the other hand, the ileum, it is vitamin B12 or the Castle intrinsic factor or the bile acid deficiency, which will precipitate gallstones, is the answer for your ileal component. Okay? So this, all in all, is the basic objective behind the surgical anatomy and the basic physiology in the small bowel. Clear? Clear? Okay. So far, any questions, any doubts, quick feedback, कोई सवाल? So we have done quite a bit today. So we came across the basic development of the small bowel. We went across with the surgical orientation of the small bowel, its basic differentiation, its bowel wall anatomy, as well as your basic physiology in the small bowel. Okay. So far, any questions? If there are no questions, thank you so much for joining today. Today is our first day of but a cell exclusion zone is a zone from where the small bowel will shed away the cells. Okay, the cells loss, basically it sheds away, that is going to be from the cell exclusion zone. Okay, chalo. So thank you so much for joining today. As today was the first day of our resuming of BLS, I try to keep it to a very basic minimal so that your brain gets oriented, you get back to the groove. Tomorrow when I come back, we are going to do the congenital disorders of the small bowel, that will be including Meckel's diverticulum, and most importantly, a very important basic topic is malrotations. Okay? Beta, if I have not done surgery, I would not be teaching surgery. If you are going to ask me about my credentials, you have to Google it across. How to make diagrams like me? Practice. When will the surgery syllabus be done? By December's end. Beta, have you done surgery? I don't know why are you asking such a non-relevant question. If I have not done surgery, I will not be sitting and teaching you. And I do it on a daily basis. Okay? There is not even a single day in my life where I have not touched blood and then come back home. Okay. Sabiston series is coming up, beta. Sabiston series is going to be coming up. That is going to be exclusive for our residents as well as people who are preparing for NEET SS. There is no greater joy than to connect to our resident level students so that we can interact at much better level. Yes, it's happening. NEET SS is going to happen soon. Don't worry. All those people who have just joined or who are new to our BLS program, for them, I have forgot to introduce myself. I am Dr. Sandeep Seeram Reddy. If you have any questions, any queries, anything that you want, you can reach out to me. I have the Telegram group that is called as The Surgery Guy. We also have the Instagram on the same group. All the class notes after the class will be uploaded to these two groups. You can just go through them as well, right? So this was the session for today. Thank you so much for joining. Tomorrow again, we'll meet at 10 o'clock, and tomorrow's discussion is going to be on the basis of your congenital disorders of small intestine. Thank you so much, guys. Thank you so much. I mean, I can't thank you enough for all the love and support that you have shown for BLS. I started off as one of my, project that I really wanted to do from my heart, and I could see it translate. Thank you so much for the word of mouth. Continue to do so. Let's make surgery learning one of the best and the most easiest one. With that for today, thank you so much. Signing off. Good night. Have fun. Bye bye.